Hi, welcome back. We're starting our lecture on inhaled anesthetics here. We just finished up parts 1 and part 2 of cardiac and pulmonary anesthesia, cardiac and pulmonary physiology for anesthesia. And now we're going to move into inhaled anesthetics, okay? History of inhaled anesthetics. I don't think you really did a history lesson about all of anesthesia, but I think the history section at the beginning of this chapter is helpful to tell you about how we ended up with the two inhaled anesthetics that we use, or three inhaled anesthetics that we use all the time, sevoflurane and desflurane. So we're going to walk through this progression and you'll start to see why these others have fallen away, okay? Nitrous oxide came out in the 1800s there. It is actually still in use today. It does have a little bit, some issues. Methionine synthetase is inactivated with especially repeated use of nitrous oxide, and that can cause bone marrow suppression. So you certainly want to use this in someone who has pancytopenia or some kind of bone marrow problems already. You also wouldn't want to set yourself up to use nitrous repeatedly on someone. Say you have someone who needs like dressing changes for burns or something, and you think, oh, I'll use nitrous every day on them. You'll eventually knock out their bone marrow if you do that. Ether was first demonstrated at Mass General Hospital in 1846. Some downsides, it's flammable. All these early ones can catch on fire, which really makes it difficult to store and use. Downside, chloroform. In addition to being flammable, it also is halogenated with chlorine. So this causes some toxicity, renal toxicity. So that's kind of an issue there. Then we come into more modern times. Halothane came out in 1956, commercially came out. It's non-flammable. It is halogenated with fluorine, which has less toxicity, but it still had problems with hepatotoxicity through another metabolite and also dysrhythmias. It can cause cardiac dysrhythmias by sensitizing the myocardium to an epinephrine. And so you see fatal dysrhythmias can come up, especially in children with the use of halothane. Methoxyflurane came out, it caused renal failure. Enflurane came out in 72, it caused a seizure activity. Isoflurane came out and really hung in there for a while, came out in the 80s. I was still using it when I started practice in 2004. And it didn't have the toxicity issues. It's not flammable. It has the fluorine, but it has been replaced since by sevoflurane and desflurane because it takes longer for this to wear off. The off time on these two is much quicker. The wake up is faster, and that's become an issue as you do more and more outpatient surgeries. And so isoflurane has a similar safety profile to Sevo and Des, but is slower to wake up. So you won't see that in the OR. But sevoflurane and desflurane are the two main inhaled anesthetics you'll see while you're in the OR, and you want to familiarize yourself with how those are administered. They're administered through a vaporizer. You want to ask your anesthesiologist where the vaporizer is and how they turn it on. And you'll also want to see where the measurements for those are. On their monitors, there's measurements of concentrations of both of these and what MAC they're at. And we're going to talk about MAC next because you'll hear that all the time. And I'm just going to define it for you so you don't have to worry about it. Okay? MAC is the minimum alveolar concentration. And all it means is it's just a way to measure anesthetic depth. Okay? It's also a way to compare between different potencies of the different volatile inhaled anesthetics that are out there. See a big table in your book on page 85 that compares all of these. And I'm going to do a little comparison between sevoflurane and desflurane next to tell you the salient points about those. But let's talk about MAC real quick first. The MAC, so when someone says the MAC of sevoflurane is 1.8, you might be wondering what that means. 1.8 is the measurement of the end tidal, meaning end tidal concentration of sevoflurane, meaning how much there is in someone's breath when they breathe out. And that would be, if it's at 1.8, that patient will be at 1 MAC. And at that concentration, if you did surgical incision on a group of patients, half of them would move with surgical incision and half of them wouldn't. So that's the definition of 1 MAC. So 1 MAC of anesthesia, 50% of the patients move, 50% of the patients don't. A MAC of the concentration necessary to achieve that with desflurane is 6. So to get to the point where half of the patients move, half the patients don't move, you need an end tidal concentration of 6 for desflurane. And you should ask your anesthesiologist to show you where those numbers are on their screen, and it will also calculate the MAC for you there on the screen. The more interesting thing about MAC, and I think I don't want you to get too hung up in how to measure it and really get concerned about that, is factors that increase or decrease MAC. Age of the patient, other drugs or medications they're on can affect it, electrolyte abnormalities. Um, all of these things can increase or decrease an individual patient's MAC. So I think it's always interesting to think about that. Given a patient's condition, it can change that. So we're always trying to suit the MAC not only to the patient, but also to the type of surgery that we're doing and also the hemodynamics. So the patient, let's say the patient really struggles with nauseousness. You may want to decrease your MAC and keep the patient asleep with propofol, which is non-nauseating. Okay. Um, you may have a patient who's older and their MAC is probably lower. Okay. Surgery, different surgeries can be, you want more muscle relaxation. Volatile anesthetics contribute to muscular relaxation. So that might be something you want for a surgery. We talked a little bit in our last lecture about hypoxic vasoconstriction and how we decrease the MAC in those cases because we don't want the reflex of hypoxic vasoconstriction to be blunted by inhaled anesthetics. Also talk about hemodynamics. Every time you bring these medications up to a good concentration for anesthetic depth, you'll see changes in hemodynamics, such as usually hypotension. We talked a lot about hypotension in our cardiac physiology section. And you can always ask anesthesiologists, how are they preparing? What do they do to treat the hypotension that comes from increasing the minimum alveolar concentration of their inhaled anesthetic? So that's a really fun thing to talk about. And you'll see these numbers and you'll see this used every day in the OR. So that'll be really great. A little bit of a comparison between the two. They're actually very similar, but a little bit of a comparison I think is important. We talked about the max, we talked about 1.8 versus 6. That's just the concentration at which half of the patients will move with surgical incision and half the patients won't. So don't overthink it, okay? If the MAC gets higher, say they go 1.2 MAC, 1.3 MAC, then you can expect the patients to be less likely to move, okay? You're more deeply anesthetized. One of the things on the chart that you might notice on page 85 is this term called blood gas partition coefficient. And I don't want to bore you like crazy, but you'll notice that sevoflurane, desflurane, and nitrous oxide all have the lowest of this number. And all that relates to, in simplest terms, is that they wake up faster. The lower that number, the faster somebody will wake up. And that's really why, one of the reasons why sevoflurane, desflurane, and nitrous oxide are still in common use today, because they do wake folks up quickly. Okay, and that's become more of an issue as we've done more and more outpatient surgery and we need to wake people up and get them home. You'll also know vapor pressure. You think, who cares about vapor pressure? Well, it talks about the vapor pressure because desflurane's vapor pressure, as you notice, is really high compared to all the rest of them. And it is in a heated vaporizer, and you should ask your anesthesiologist to show you the vaporizer that desflurane is in because it is special. And it just allows us to keep that desflurane in a gas form so that we can give it to the patient through a breathing tube. Okay, so you should ask to look at those two vaporizers. They look different, and desflurane is a special vaporizer because of that vapor pressure at room temperature. Both of them decrease MAP, mean arterial blood pressure, by decreasing systemic vascular resistance. Both of them do that. And these hemodynamic measurements that we're talking about here in the middle, we should remind you, this is in healthy volunteers. This is not in a sick patient having surgery with blood loss or any other kinds of issues. So all of these talk about what happens in a healthy patient. You see an increase in heart rate with both, slightly different time frame, but they both increase heart rate. And all in all, the cardiac output is minimally affected, okay? We should compare this to nitrous oxide just briefly. Nitrous oxide does not do this. So oftentimes anesthesiologists that still use nitrous oxide use it because there's less decrease in a MAP. They use it with sevoflurane, with desflurane to minimize that decrease in blood pressure. I personally don't use nitrous oxide in my anesthetics anymore. But if you see people using it, you could ask them why, and I bet that's probably why. You also see increased respiratory rate and decreased tidal volumes with desflurane and sevoflurane. So if someone is breathing on their own, like through an LMA, They should, and they're just on sevoflurane, you don't add any opioid in, their respirator should increase and their tidal volume should decrease. And pungency. Desflurane is pungent. Sevoflurane is non-pungent. So you use sevoflurane for mass conductions of anesthesia. So if you have a small child coming in that will not allow you to put an IV in, and you have to put them off to sleep through a mask, you'd use sevoflurane because the pungency is it's non-pungent, meaning it's not irritating, it won't make them cough, and it tends to be better tolerated that way. So that's when you'll see that. So if you ever see a mass conduction, you'll see us using sevoflurane, I'm sure of it. And these are all things you can talk about with your anesthesiologist and when they see these, and how they prepare for maybe the decrease in blood pressure. And you should be asking about all of these things, okay? Malignant hyperthermia. You're going to touch on malignant hyperthermia, often abbreviated as MH. Everyone uses a lot of abbreviations. Malignant hyperthermia is a life-threatening complication of anesthesia. It's inherited, so it's genetic. It runs in families, and it's an increased metabolism, skeletal muscle metabolism, and it's triggered by inhaled anesthetics and succinylcholine. And the treatment here is just kind of briefly written: discontinue the triggers and administer a medication called dantrolene, and treat potentially life-threatening electrolyte abnormalities. Primary one would be hyperkalemia. You could ask your anesthesiologist if they've ever seen malignant hyperthermia, if they've ever treated a case of this. It's fairly rare. It could be an interesting point of discussion. It could also be an interesting presentation topic for the end of your rotation. So this is where we're going to leave it with anesthetics. I hope that you learned a lot. I hope it wasn't too boring for you. And I hope that you can really use this in your time in the OR. And thanks so much.